My name is James Brood. I want to welcome everyone to today's innovation chat, focusing on the COVID-19 response from a healthcare and an AI perspective. Today we have Dr. Robert Brenner from Valley Health. He has a really distinguished background in the healthcare system in New Jersey, and I'll let him talk about that as well. And then we have Simon Samaha, who is also has an impressive background in the healthcare sector, both in the hospital and other sectors, as well as consulting to healthcare leaders around the world. So with that short introduction, I'll let these folks more articulately talk about their background and what they're doing today. So I'll start with you, Robert. Go ahead.
So I'm the president at Valley Health System of Clinical Integration and the Physician Enterprise. My background prior to being at Valley Health System, which has been the last 4.5 years, was at Summit Medical Group, working with, having the opportunity to work with Dr. Samaha, who's also on this video. Prior to that, I was in hospital administration, and then I was a residency director way back in my career. But that just puts it in perspective.
Thank you.
Thank you. So good afternoon, everybody. Simon Samaha. I'm also a physician by training, although I haven't practiced in a while. Recently, 2 years ago, I started my own company where I focus a lot on healthcare consulting in a very niche areas. And actually, interestingly, before COVID-19 hit, I was working on a project with a AI company out of Ireland that just opened offices in New York City. The company name is Altada. And what we were focusing on is building an AI-empowered solution for physician practice revenue cycle management. And then this whole thing of COVID-19 hit, and a conversation with the CEO there, we basically agreed to take this time to focus on our, I guess, intellectual power in providing services to support hospitals like Valley in their fight against COVID-19. So we've spent all the time since this whole pandemic happened, building forecast models and sharing these models for free. And that's the other commitment we've made, is that all the work that we do during the pandemic will be at absolutely no charge to all the systems. So we've been building forecast models that have been proven to be very well within the actual reality of what's happening, and we've been distributing these models across the United States. Our biggest focus has been New Jersey and New York, just because of the impact that we have seen there.
Great, thank you, Simon. So Robert, why don't you talk a bit about Valley's response and also the healthcare system in general, particularly in New Jersey. But first, give us a background on Valley Health. Some of our participants here today may not know.
Okay, Valley Health System is in Bergen County predominantly. We're we have the third or fourth largest hospital based on number of admissions in New Jersey. Take care of a fairly complex number of patients. Prior to COVID, it was, we have a cardiovascular service line, a very extensive neurosurgery service line, and women's and children, and some others that I can mention later. And we also have a Valley Medical Group. We have a very large home care. Our Valley Medical Group, by the way, has 72 different practices in 52 different locations and approximately 50 different specialties and 400 providers. So we're a fairly comprehensive health system and quite busy.
Okay, and talk about the response then, how you've seen this pandemic coming.
So what I'd like to do is set the stage before I talk about the response, because on March 14th, we had 0 cases of COVID. But what we did hear is the news about Teaneck and the fact that they were getting, it was somewhat of an, called an epicenter. But what we watched over the ensuing days was like a storm front coming upon our areas of practice. And the next thing we did is we saw an exponential rise in number of cases. And in fact, what I had done is reached out to Simon and asked for his assistance in terms of projecting what we were up against. And we did get an accurate projection, but I wasn't happy with it early on because it looked daunting. And Simon said, unfortunately, this is the way it's looking, and it really pretty much turned out that way. But just to tell you where we are right now. So we saw our first case on the 14th. We hit a peak of, and I hope it's our only peak, of 238 cases in the hospital. Today, we sloped down over the last couple of days to about 207. Our admissions are starting to slow, it kind of be in the mid-20s, but they were as high as in the 30s and 40s. So it's leveling off. The one thing we're unfortunately not seeing slowing is the expiration rate, and that is mostly because this disease lags, and you could have somebody on a ventilator 2 or 3 weeks. So we've had 173 deaths since March 14th. Yeah. This is staggering, and I won't even go into the operational side of caring for 173 souls and bodies. So it was very, very tough. The one thing I'm proud of is that we only have, once we hospitalize somebody, we're only getting about 14% on the ventilators, which means that we're able to keep some of them from going on the ventilator, which has turned out to be a good thing. Because once you're on a ventilator, it's pretty difficult to get you off in this circumstance. The state average is about 25%. We were hovering in the mid-30s on ventilators, and that was before we were able to procure a whole bunch of them. But then now we're down about 27 to 30 on any given day. So the other thing is to talk about ours. This kind of comes on you, you're surprised. It's unfathomable what happens in a crisis like this. The first response was kind of to close things down, and basically we closed to non-essential visitors except peds and maternity and so forth. And then we closed down to all elective surgeries and non-urgent procedures. The next thing we did is we had to close down our offices because we were getting some of our own staff sick that were sick, and then we were inundated with patients with complaints. So we started to cohort was the next stage of what you do. And a lot of these things no one told us how to do this, although I'm sure there were articles written years ago about what to do in a pandemic. But you start to cohort, and we cohorted floors where people were either PUI, which is patients under investigation, or confirmed positive, because then there was a lag in testing. And then we also created negative pressure rooms. And then we also cohorted in the ambulatory setting. We closed down practices to only essential visits and had people being seen with in our urgent cares for when they were sick and required testing. At the same time, so it didn't happen linearly. It happened, all together, where telemedicine grew exponentially as well. We started using one platform, and we went to 3 or 4 different platforms because some were working better for some people, and some patients were finding some easier. So we did that. In the midst of all this, we're trying to get PPE, and you had vendors selling us. Not vendors, you had people that were out there dealing with PPE that really didn't meet specs or were knockoffs. So you had to be, we learned that we had to be very careful. At this point, the other thing that we did is we, in anticipation of a potential heightening of the volume, which I'm not so sure of yet because we've seen the flattening, and I'll rely on Simon to tell us. We actually deployed staff and physicians, even pediatricians and dermatologists, gynecologists, APPs, everybody to help on the floors with the burden of severity. It wasn't the absolute numbers in our census. It was really the severity. The last thing I'm going to talk about is really what innovation we've seen. They say necessity is the mother of invention, but what I witnessed is incredible. I mean, first of all, everybody was doing things that they ordinarily wouldn't do. I was contracting with a sewing company to make masks, and that's the furthest thing from my mind about what I'd wind up doing. But we had anesthesia going to Home Depot to get PVC piping to figure out at that time we didn't have enough ventilators. So we were figuring out how to get two patients on the same ventilator and devising something out of PVC piping. We rented a commercial laundromat to launder gowns because we didn't have enough of the disposable. We had an intubation hood to preserve our physicians and staff who were intubating our patients. We put holes in the intensive care walls. We were drilling holes so that we could put the IV tubing through it. We had handmade masks. We had converted K95s through the use of a 3D printer to print a device that made the K95 mask so that it was fit tested properly. It goes on and on. Plasma programs that we got. We have 17 patients on plasma. 13 of those were people that were extubated, repurposing staff. There were no rules in this whole thing, and it is an experience that I'm sure many of us in healthcare will never forget. So I'm going to move on to turn it back to you, James.
Thank you, Robert. And Robert, fix your camera. We're not seeing you, so maybe your camera turned off or got unplugged. So if you could just check that and pop that back on, we can hear you fine. So,
my camera is on.
okay.
I'm seeing myself.
All right. Well, we'll
not sure what happened.
All right.
You know what? It may be my connectivity.
It may be. You know, you were freezing up before, so we understand. So I'm going to move over to Simon right now. Simon, tell us, number one, Simon, what are you seeing? Robert alluded to the innovation that's going on in hospitals, some of the real ingenuity in trying to get supplies, etc. Talk to us about that, what you're seeing in general, sort of add on to what he spoke about as far as innovation, how the healthcare industry is responding. And then we could talk about more of the AI side.
You know, very similar, I would say, to Rob covered a lot of the things that we're seeing in the market. You know, I can summarize them into a lot of creativities with managing supply resources, a big shift to telemedicine. I'm hopeful that these obstacles that the government removed from to allow more telemedicine, that they're not be put back in place afterward, because I think a lot of what slowed down the progress of telemedicine is a lot of the in my opinion, unnecessary regulations that we were dealing with. The other thing which we're seeing and a little bit unusual is you remember I'm mostly in the information field. So that's what I see the most is the crowdsourcing of data, organization sharing together data, and using that crowdsourced data to get some very valuable insights, and that's how we're able to refine the prediction more and more. The other thing which I have not seen in the U.S. yet, but it's getting a lot of traction in Europe, is distance apps. So basically using a combination of smartphones, geopositioning, and testing to be able to identify when somebody turns positive, to identify who were the relevant close contacts that you have to bring back in and test, so in preparation to the return to normal. So a lot of also what we're seeing right now is more people focused on how do I get back to normal. So we don't think the return to normal, whether we're talking about changes in policy or operationally, is not looking like a switch. We're going to switch and the next day we're normal. There's going to be a transition phase, and we're actually not sure whether this transition phase is going to be COVID-free or not. So there's a lot of modeling that we're working on to say, okay, this transition is going to be 12 to 18 months, and how do you transition back during that period of time? So a lot of it is now we're seeing, and again, my area of focus is mostly related, centered around information management, is organization being more adaptive to reacting to predictive information faster than they used to be in the past. So the cycle of an information, of a organization taking information and responding to it has been the shortest I've ever seen in healthcare. And to me, this is what a key recipe as to why we've seen a lot of these hospitals being resilient is they kind of shorten their cycle immediately. So I mean, what I would add to what Rob mentioned is a lot of innovation in how they function, how organization functions in relation to integrating information and knowledge.
Simon, if we look outside the US, is there a healthcare system that we should be emulating?
Yeah, well, not the Chinese one. I don't know, and I'm involved with a couple of projects, and I've also had the opportunity to see the early stage of the plan in a couple of European countries. The problem you have, it's a combination of, or the reason why this is a fundamental problem is, one, we really still don't understand the nature of the disease, the nature of the virus. There's a lot of conflicting information. There was recently a report coming out of Germany that basically, according to that analysis, which I haven't had my hands on the analysis and details, but it's questioning, it basically says that for the virus to be transmitted, you need a prolonged intimate contact. So, you know, all these contacts through, I don't know, mail and in the supermarket, that study shows. So we still don't understand it. And as a matter of fact, there's an important element in disease transmission called the R0, which is basically when somebody is infected, how many more people they're going to infect. I mean, even something as simple as that, we're struggling to figure out what is that number. So you got that issue, and the other issue is the social mobility, right? There's a lot of evidence in the past that there's a direct correlation between how mobile societies are and how prosperous. So you can imagine that people want to become more mobile, but we don't know to what extent that mobility is relevant or not in closing the disease. And the last thing is the population, I would say, behavioral characteristics. You know, you can't see, there's no way a solution that was implemented in one country is going to work in another country. So I have not seen that a healthcare provider, I gotta tell you, I am super impressed with the healthcare system in the United States. I mean, the level of response, especially in areas like northern New Jersey and New York. And I think Rob probably, it's unless you've been in the hospital and managing hospitals, I would not believe that there is a business that would have survived what a Valley Hospital has survived. This immediate shift from having elective patients to suddenly you're flooded, and your entire business model, and I know we don't like to talk about this in healthcare, but that's the reality of it, literally flipped upside down in one day and still yet be operational. And also keep in mind, most hospital systems don't have 300 days cash on hand.
Yeah, it has been very difficult, Simon, for many of our neighboring hospitals to sustain themselves. And
yep.
the financial damage that's being done is very great.
Yeah.
I won't even go into how many millions we're losing, because right now we're concentrating on keeping our patients alive. So
yeah, but you're still functional, and that's what I find amazing. So I think this is, you know, I wouldn't say at this point in time, you know, there's a place I've looked into and like, oh my God, we should be doing this. I think if anything, if I was to, you know, see what else can we do better, maybe a little bit, maybe this is an opportunity more for some more public-private partnership. I think one of the key things we're going to need moving forward is a much bigger ability to do testing. And maybe there's an opportunity there to create more testing capabilities, more innovation in testing, and open up that lab testing to be, you know, today it's very difficult to be in the lab testing business.
yeah.
So maybe there's some opportunities, same way we relaxed on the telemedicine, is to create more competitiveness and create more kind of, market-driven solution than thinking that the government is going to solve every problem that we have.
I agree with that. The only thing we're grappling with is how do you use the testing?
Yeah.
Because we're looking at putting in place antibody testing, and we're days away from that. The problem is when you do the antibody test, can you go out and reassure those staff that, hey, now you have immunity or long-term immunity? We're not sure. This virus is all new, and it's just reading some of the recent articles. It's not acting like some of the other coronaviruses.
So, and again, this is probably a plug to why I think crowdsourcing of information is so critical. The more information we can get from different places and be able to assimilate that information right now is going to be very critical. It's the point that Rob is mentioning. And again, let's talk about coming back or going back to normal, right? There's some countries that looking at categorizing people into 3 categories. Those who are immune, those who are sick, and those who are susceptible, which is really kind of a way to try to retrofit an entire population into the epidemiological curve. But how do you determine that somebody has recovered and is immune? We don't know that. We don't know whether people who have had, so there's evidence today that people are relapsing with the disease. So, but there's not been enough studies. We don't know why people end up on the ventilators, and some don't end up on the ventilators. And if you get on the ventilator, are you going to become more immune down the road or not? So there's a lot of questions there that I think there's a lot of opportunities to start collecting the data right now. So we're much better prepared to deal with this recovery to normal. So that's I guess my plug into creating more crowdsourcing data right now.
Yeah, you know what, Simon, I agree with you on the crowdsourcing. It turned out that we would have daily phone calls with other hospitals that were getting hit with this. And I think that all of the innovation was learned from one organization to the other. Somebody said to us that if you build a hood over a patient, you're less likely to have your staff contaminated when an intubation occurs. So the next thing I know is we're building our facilities management team is building a intubation hood. So it just all of the information going back and forth, what worked, what didn't work, is Plaquenil actually working, is it not, and a lot of it's anecdotal. A lot of it is not hard and fast information.
So let's talk about the AI work you're doing, Simon. And I'd like to also mention to the participants on the call, I have a few questions. Please submit your questions and we'll get to them shortly. In the meantime, Simon, talk to us about the work you're doing with AI.
So I think, AI is becoming the new buzzword that a lot of people are using. And I would just cautious people from that term. The whole essence of an AI is the fact that it's the machine learning, or basically the machine teaching itself knowledge rather than writing a code where you tell the machine what to do. We're now building these machine learning models. So what I would say is what we've done right up till now, and maybe I'm being too specific and picky on the terminology, we're using more epidemiologic models, and the most common one that everybody is using, and I've seen being in the United States already mislabeled as an AI, which is not an AI, is called SIR models. So this is a model susceptible, infected, and recovered. And you can imagine, we don't know who's susceptible, we don't know who's infected, because the testing is still not as pervasive as we need to have it, and we still can't define the recovery, but we're still using these models, and they're providing us with some valid prediction. The AI, I think, is coming fast and furious in the post-peak period. There's a lot of work we're doing, and I'm working exclusively with a company. I mentioned Altada. We're looking at the first thing we're looking at is building predictive models that would, on an ongoing basis, basically learn and teach itself and refine itself. The first use case we're building, and we're in the midst of doing it right now, is volume. So it's going to be almost impossible for people to predict what is going to be my volume in the next 12 to 18 months. So we're building as the basic foundational use cases, the volume. There's also some decisions that hospitals are going to have to make. Rob mentioned in the beginning of the conversation is, we have multiple service lines, we have cardiology, we have all these. He is going to have to make a decision coming out of this COVID or as in the transition. What service line do I start with? Where do I focus? How do I rebuild my elective? Because, at the end of the day, although they are not for profit, which, a significant number in the United States are, they still need cash to function. So he's going to be hit with a very complicated question, which is, what is going to happen to my volume organically? And what intervention I need to put in place to manage my volume, which service lines I'm going to have to go after. And that's where, the foundation of what we're building is this use case related to volume and census. And then from there, we're building sub use cases related to capacity, related to resources, related to cash flow, revenue cycle, and all that stuff. I would just want to mention something that also is going to be very, very relevant to a lot of the hospitals in the United States. Rob mentioned something very important, which is the lag time, right? You have the virus infection, you have the symptoms, then you may or may not become sick enough to be in the hospital. And if you're in the hospital, you may or may not be sick enough to get to the ICU and potentially or the risk of death. So that's why you see this lag time between the virus plateauing, because remember, we're measuring positive cases, and then behind it comes even after we plateau on the number of cases, we're going to still see an increase in census, because one of the things we predict is going to happen is the discharge planning is going to get a little bit messy. So hospitals are going to have problem discharging patients, so that's going to cause the census, and the mortality is going to probably lag behind 10 to 12 days.
So, Simon, what we're concerned about at this point, even though we've had a leveling, I'm sorry about the gap in my video, by the way.
So, we can see you twice now.
But I'm back. One of the issues is the nursing homes.
Yes.
So we can't easily send back to a nursing home,
Yep.
and
Yep.
the state just mandate that they have to.
Will you be able to rejoin
put their
on this if I close it?
together?
Yeah.
And so not all of them are capable of doing that.
Yeah.
And so we're having difficulty getting the nursing home.
If I close this, will you be able to rejoin from in here?
There's a huge uptick in number of cases in the nursing home.
Yeah.
And many of their families
I
want
want to
to
end it here, but will you be able to rejoin?
Nursing homes don't want to deal with it either, because it's a challenging illness. They're not prepared with PPE and rest.
Yeah.
So my fear is the surge from the really, debilitated nursing home patients, which is even more challenging.
Yeah. So we're building that in the use case model, Rob, which is the implication on your post-discharge. And that's why I'm saying the model has to be continuously learning and refining, because the dynamic there may change in two ways. One is the capacity backfill on you. And the second thing is there actually would be the perfect environment for a second or secondary outbreak. So, and that's going to have also a back review. This is where, something like a neural network AI is going to be incredibly helpful, because you're going to have to continuously learn. And this is, again, the term continuous learning to me is the critical part of the AI. The other thing, which is something that also we're looking to take into consideration, and we've learned this a lot from my colleague in Ireland, is they're seeing a significant increase in healthcare workers. And I'm, anecdotally, I'm seeing it here, where, so what's happened in one of the hospitals is in Europe is the ICU team got hit, and then they had to replace it with a junior team that is not as experienced. So now you have outcome issues, and then you have again, patients staying longer in the hospital and so on. So these dynamics become so interrelated and so complex, and that's kind of the second wave of our predictive modeling is, what kind of resources you need and how do you monitor them, and then if things are shifting from what is, kind of the delta between expected, predicted, and actual, is for you to jump immediately on it and figure out what the hell is going on. Was my prediction wrong, or was it the fact that I have something new that just showed up? So that's a lot of the stuff James says around predictive modeling. And we're literally in the midst of it, trying to figure out what are the best models to use. We're looking at Forest 3 model, at KN models, and different models. And these guys in Ireland that I'm working with know the stuff far, far better. The other one is natural language processing. So there's been a couple of very interesting opportunities there that came out specifically in call centers. Now, if you enjoy that area, and I've spent a lot of time reading about it and learning, airline industry has been using chatbots in call centers for years now. And they don't use them to replace the human. They use them to enrich the conversation between the contact center employee and the person calling. And we're seeing in Boston, one of the hospitals actually, they were flooded with contact center calls. They actually included a chat bot to screen the calls and then direct the calls later. Now, I would love to see more hospitals embedding and healthcare system embedding these, because they have tremendous opportunities post the corona. Believe it or not, a big dissatisfier in healthcare is actually billing. And billing operation gets a lot of calls, people inquiring about their bills and so on. So there's a huge opportunity there to see these chatbots implemented. And the last piece I would talk about, and this is for us is more of a phase 3, is embedding AI into automation of workflows in hospitals. So for example, in imaging, you have results coming in. And again, we're not looking into the concept of you're going to have AI replacing people, but it's enriching the work environment. So take, for example, a result. You can easily have an AI solution that sits on top of the results, reads it, and escalates the results based on content in it. So it's opening up a lot of opportunities. The CEO of Altara is, and I can tell you the biggest problem we're facing today is where to focus. And our immediate focus is on phase 1 or phase 0, we're calling it, is the modeling of volume. So people like Rob can see what's going to happen in the future as far as his volume, and can simulate the decision he's going to make. What if I decide to open up more cardiovascular services? What's going to happen? And somebody like Rob intuitively will tell you, look, if I open up, build up my cardiovascular, well, I'm going to have some other implication, right? I'm going to need more people in the ICU. I'm going to need more people here, more people there. And so creating these simulation models so he can see in the future what's happening and what's going to happen in the market to predict and react to it.
So based on the modeling that's been done, we've done a couple of things in terms of capacity. So we doubled our critical care capacity. We almost tripled our ventilator acquisitions, and we increased our med-surg bed capacity by 30%. The question then came down to who is going to staff those increased beds.
Yep.
And so here you have all this new capacity. Okay, we're ready for what the modeling's telling us, but then how do you restructure? And this is where I think innovation came down, where we actually repurposed and repositioned staff, and to have somebody who's on the breast care service in an ambulatory breast service now rounding with the hospitalists. And if you go up there, I'm rounding every day and, visiting all of the people that are throughout the hospital. It's absolutely incredible to see. They're all pitching in and making it work.
Yep.
On the human side of this, taking it from the calculations and the IT and the AI, then moving it into reality. It's really a tremendous thing to see.
Simon, let me cut you off there just because there's some questions. First of all, information that you're forecasting, Tom asked where that could be found. Would you just give your contact information?
I'm happy to share them, with all the disclosures that lawyers asked us to do, so they'll be there.
All right, great. And then before we get to some questions, I do want to hand it over to Rob, because Rob, has just overcome this virus. So Rob, tell us your personal story and share with us what you've experienced.
I do want to say, Jim, there's so many other stories out there that are much more impressive than mine. If you take asymptomatic 0 to a 10, who's life-threatening illness, I was maybe a 1 or a 2. It was striking, though, to have an illness that I was entering it. I was definitely fearful, saying, okay, in the context of what I'm seeing, this could be really, really bad. Although 90% of people get through this, like a cold. So I had something between a cold and the flu, and, it was, I definitely was fearful for a while. I think my colleagues were afraid to have me come back. I felt like I had the scarlet letter A, on my back. And my whole house got it. And so it was fearful, definitely anxiety about how this can affect my house. Did I actually get it from one of my children is another thing that I would consider, because they were in New York and definitely hit New York, and they did have some symptoms. So I don't know whether I got it. You're not going to know whether I got it in the hospital or not. I hope to be a donor if I do have a high enough antibody level for some plasma donations. But, my experience, I really can't go through the detail of my experience compared to what people are going through here and what I'm witnessing.
Right. So before we get to questions, I want to just ask each of you, share with us just one thing, a takeaway from this conversation that the audience should know about innovation and this terrible COVID pandemic.
Yeah. I would say that this was a time where you didn't have all the answers, you didn't have the experience, and if there was any glimmer of wisdom, it came from making decisions without having the information necessary. Granted, we did have modeling, but there were a lot of decisions to be made that you didn't have a definitive answer. It wasn't like, okay, yes, you treat this with this antibiotic. It was, could this work? Would that help? How do we get this done? And to me, that was watching people around me work in that environment and people extending themselves way out of their comfort zone. That's the silver lining in all of this.
So that type of agility, which you don't normally see in healthcare, really came to the fore, I think, is what you're trying to
It forced us to be that way. Usually we're pretty inflexible in healthcare. It's pretty, pretty rote, but that was not the case.
Got it. Okay, Simon, share with us just one thing.
I would take what Rob had said is this organizational agility in healthcare that we've always been accused of not having. I think we were almost like battered children. We were convinced that we can't do it, and we were told we can't do it because we can't do it. And I think healthcare and for the most showed that it can. So my I guess it's more of a desire and a wish that this agility stays after the COVID. Come out of it stronger from an organizational agility than before, because you proved that you can do it. I mean, honestly, and I don't want to get into any form of politics, but the healthcare should be the first one begging for relief, and you don't hear that. I mean, so I think I would hope that this executive or corporate agility stays. I think also, I would give credit, which is, it's not acting without information, is recognizing that you have enough information to act. What we see in a lot of organization is this kind of analysis by paralysis. Rob had enough information to make all the decisions he needed to make, and he made them. I think that's also something from an organizational development, if can be more, promoted later and then pushed through the organization, would make them much more successful.
Yeah, maybe it's better to say not the information, but less information.
Yeah, the right ones.
Yeah.
Enough.
Enough.
So the learnings from this crisis should improve healthcare into the future. So this crisis won't be wasted, right? That's what we always say, don't waste a crisis. And this is one of the big upshots from this crisis. Okay, let's get to questions. So we have a question from Clark asking, for entrepreneurs to work with hospitals and technologies within hospitals, is that something that is the hospitals will now be more open to working with innovative entrepreneurs to sort of collaborate and make their systems more responsive and better?
So I think we're always open to different entrepreneurial innovation, and I think we have to maintain a certain percentage of that where we do explore different entrepreneurial ideas. The other thing that I would say, and right before this started, we were breeding innovation within our organization. We had gone to many conferences. We created some conferences and teaching our leadership the principles of innovation. We had resources. We had committees set up. And, a lot of us said, oh, we don't even need all that because we were forced to innovate. Yeah. And I think at this point, what my preference would be to make it part of the DNA of this organization that we think innovatively on how to problem solve. And don't get, like Simon said, analysis by paralysis, which we're famous for.
Got it. And Mario asked, what is the impact of innovation and crowdsourcing on privacy and Hipaa?
As I can tell you, I wish you had my friend Alan from Altada. He's actually wrote this the standards in Europe on AI and ethics. I don't think the issue honestly is the privacy. We're finding people. Here you go. You have a perfect example of a physician executive who went online and talked about his disease. I think it's always been fascinating that when you ask people, it's not the privacy is not related of sharing the information, but more important is what's done with the information later, and that's going to be the biggest problem. And I can tell you, this is a big issue we're dealing with today related to the return to normal. One is, this whole distancing and proximity is critical, but who is willing to allow a third party, whether it's the government or not, to have access to your mobility on a minute-by-minute basis or 15 minutes period without cares. So that's a big issue we're dealing with right now. And the second thing is the status of your immunity. So it's a bigger problem right now because it's a convergence of technology, which before COVID we were always concerned about our privacy. Put healthcare on the side. It's really not healthcare specific as much as it is your individual liberty specific. And I think it's just magnified because now you have a public health problem that requires both an individual and a collective solution. So it's probably the most consuming aspect. I can tell you right now, if we put privacy on the side, we can come up with a solution within half an hour. The privacy issue is and rightly so, is the biggest ticking bomb in this.
What did happen though is the HIPAA rules were relaxed to a certain extent during the crisis, allowing a little bit more flexibility. But still, with all of these laxing of rules and regulations, it still is a problem, as you said.
Great. Okay. So next question is, you mentioned the German study, Simon, about intimate contact being required for transmission. Can you talk about that more? And do you think AI will help us understand this? John wants to know.
If you can, and again, this is now where we're in an era of, or in a period of time where we're mostly driven by anecdotes or very, very small sample size. I think if we, and the other part of it is the whole foundation of COVID is basically a positive test. And we're not testing enough. And I can give you hundreds of quantitatively supported why we're not testing enough. So it's very difficult to now come up with anything that can pass scientific rigor, unless we have something in place. I think we need two problems to be solved. One is we need some kind of a digital recording of proximity. People cannot remember. I mean, Rob gave you a perfect example. Did I get it from my kids, or did they get it, or did we all get it together, or did I give it to them? He can't tell because we can't trace back all these different contacts. We can technologically, but the issue is still around the privacy part of it. And the second one is testing. So what we're pushing for and promoting is, let's fix the testing. That's the fastest thing that we can fix. We need to get it. Well, I give you a very simple statement that scares me is, and I hope it's not the same for Rob, but every conversation I've had with the CEO of a hospital, I ask them a simple question: can you test all your workers? And the answer is no.
It's a voluntary basis at this point.
Well, the people I'm talking to, they're telling me they don't have the resources to test them if they all say yes.
So, right, they don't have the resources. But if you go back and you say, to be part of this medical staff or to be part of this organization, you have to test for measles and things like that.
Yeah.
And varicella. It may be that you're going to, in a year from now, as part of employment, be tested for corona.
Yeah. So to answer the question about having real, scientifically proven answer to the transmission of the disease, you need a reliable testing, and you need a reliable proximity. That's the only way you can go back. Otherwise, what we're going to have to do is wait for a year and a half or 2 years and go back and retrofit models. I mean, we did some, Oliver Wyman built a really nice model that they launched early on, but it required an input, which is the social distancing. How effective you think? Well, I can't tell what it is. So what I did is I used this model in retrospect, and I was able to show in areas where social distancing worked. But we're talking about a magnitude of, in 10, 15, 20, 30%. It's not, we don't have the level of precision to be able to conclude this work, or this is the cause, or this is how it works. The only way you can do it is high testing volume. And the other thing also keep in mind, like, for example, the study from Vo in Italy, which was the town where it was the first mortality in Italy. They tested the entire town, 3,000 people. 60% of those who tested positive never had symptoms. So again, unless you do testing and proximity, we're not going to figure out exactly how the transmission of that disease works. In the short-term future. I mean, maybe in 2, 3, 4, 5 years we will, but not in the next few weeks, so we can answer questions that related to policy making.
Right. So let me ask, and there's a couple other questions, but one comment from Alan, your partner in Ireland, says regarding privacy, I'm gonna read this perfectly so I don't get it wrong. Legitimate interest is weighted for privacy. Data is only used to protect life. Trustworthy AI empowers privacy by design. Also, data minimization counters breaches of privacy. So I hope I got that right, Alan. But the question from Michelle is, when do we think people will go back to school, whether it's K-12 or college? What's your I know you don't have a crystal ball, but what is your educated guess on if that will happen in the fall?
No. I mean, here's why I say no with confidence, right? Let's take the example of New York and New Jersey. We know that New York had a huge impact on New Jersey. And then if you follow the map in time, you see Florida start picking up. Thank you for the snowbirders coming down here to Miami. So the problem is with mobility, you're going to create a lot of these issues. The second thing is you're going to have to weigh the risk versus, kind of the benefit or necessity. You can do all the stuff online. What is the benefit in putting back everybody in school where you have high duration of close contact? So that's why I'm very reluctant. The other thing is, if you look at the models, we're seeing that United States, if you look at the United States, you have multiple clusters. The country is not moving in one. Now, interestingly, in the last few days, everybody's converging to a growth ratio of like 4 to 5%. But here's the second part of the problem. The data is being reported at a state level. When you dive into the state level, the counties are behaving different. Then when I dive into the county, the townships are behaving differently. So to come up with solutions, we don't understand how this is spreading. And then the data that we have that is being used for policy making, at least what's being mentioned on TV, is more at a state level. And I don't understand, I just can't figure out what is the capabilities we have in the government, in the local government, that the state is not going to be able to make decisions on a state level. It's going to have to be more local. And the more local government does not have the capabilities to do all these analysis and figure it out. And then, to understand where people come from, how much they move, what's the implication. I just can't figure out that intuitively that the risk will deal with the reward. Now, there's also consequence of not opening schools, has economic impact on people. If my kids are not in school, I cannot go to work. This is some of the issues we found early on with the hospital being impacted with the labor force. So I just can't see schools opening in 2020, maybe 2021. But we'll see.
So Rob, what do you think?
So I think there, in terms of going back to school and maybe lightening up the social distancing, I just created a video for my community and asked that we continue this, because we've seen, I think, a positive impact in the Bergen County community. But I'm not ready to say, let's let that go and see another, and some of the other countries had another peak. And so I'm very fearful of that. When things will go back to normal, I mean, I would rely on people like Simon to help me figure that out. It's not an easy question, and from my perspective, it would be a guess. What I'm focused on very much so is making sure that I have the capacity to handle the influx of patients and hopefully save some of those lives. We are having a good number of discharges. We're seeing things level off for the last week. I want to see that it stays that way.
Yeah.
And I do think that, Jim, that there's going to be a lot in terms of how healthcare changes after this. I think we have an opportunity to take a good look at how we've been functioning as healthcare in this society, in this country.
Right.
Yeah, it'll end up being a very local decision, and I would say it's probably going to be more. I think universities will be the most delayed, just because of how people come from all different parts of the countries and sometimes the world. Local schools is going to be more of a local decision. I mean, if you look at New Jersey right now, Bergen County is plateauing, right? Still, a high number of cases. If you look in the south, Camden County went up, plateaued a little bit. Everybody, breathe a sigh of relief. But if you double click on Camden County, there's a couple of townships, Voorhees is one of them, that is still seeing a significant increase. And what's interesting is that path of increase is not similar to the early rise of the corona. So early on, we were seeing every day an increase of between 25 to 40%. In the new area and in the new increases, I'm seeing more in the 15 to 20%. So they're different patterns. And I don't know, is it slower because of social distancing, or it's slower because other factors like the density of the population, the number of people per household. It's one thing also we're not talking about is we briefly touched on is the virus is creating or is part of the symptoms we're seeing are due to the response of the immune system. Well, we know that different populations and different ethnicities have different immune systems and the response to immune system. So this is why I'm saying this is, we're taking a very single dimensional view of the transmission and the disease impact as being contact, which is important. I'm not denying this, but there's all other factors now. When we saw the distancing kind of being managed, and we're seeing different aspect of the impact. The density, the number of people per household, your ethnic background. I think there's going to be more and more studies. I don't know how much health disparity is going to be also a factor when it comes to mortality. It's something we're starting to kind of put into the model, to see whether cities and townships that have a higher health disparity have different outcomes. But it's too early to say and to predict. I'm just having difficulty thinking that this back to normal to the point of having schools open is going to happen this fast.
It's going to be a new normal.
Yeah.
That's for sure. Before we close up, I've asked Simon to share a poem with us.
So that's the worst thing you can ever. I mean, it took me more time to find a good poem than to write, yesterday a 500-line Python script. But anyway, so here's the one. Here's the
Go
one
for it, Simon.
what's that?
Go for it.
Okay, so this is the one I found that I like the most. I shall be telling this with a sigh, somewhere ages and ages hence. Two roads diverged in a wood, and I took the one less traveled by, and that has made all the difference. I think this is just a testimony of some of the tough decisions people had to make, and I think they're going to remember forever not only the decision, but their ability to make these decisions.
Well, thank you for that, Simon. I want to thank both of you, Simon and Robert, for sharing your time and your keen insights today with all of us.